Welcome back to your custom deep dive, The Learner. Today we are tackling a topic that, honestly, feels less like standard medicine and a bit more like a high-stakes tightrope walk.
That is a very accurate way to put it.
Right, because usually modern medicine is viewed as this purely restorative act. You take a pill, you get better. But treating blood clots is completely different.
Yeah, it really is. It's a fundamental paradox in cardiovascular pharmacology.
Exactly. You have to dissolve this potentially fatal blockage in a patient's veins, and you use blood thinners to do it. But the terrifying catch here is that the very mechanism that stops the fatal clot, well, it's the exact same mechanism that can cause a patient to dangerously bleed out.
Right, because you are actively inhibiting the body's natural coagulation cascade. You have to, because it's gone into pathological overdrive, creating an acute venous thromboembolism.
Which is a huge problem.
Massive problem. But, you still need that cascade to be intact enough so the patient doesn't suffer a catastrophic internal hemorrhage from, say, a minor microtear in a blood vessel.
Just an incredibly narrow therapeutic window.
Very narrow. It leaves almost no margin for error.
Which brings us to the mission for today's deep dive. We're looking at a really landmark international trial, and it's titled Bleeding Risks of Apixaban versus Rivaroxaban in Thromboembolism Treatment.
Two absolute heavyweights in the field.
Oh, without a doubt. For anyone following cardiovascular medicine, Apixaban and Rivaroxaban are the titans. I mean, they are the most frequently used direct oral anticoagulants, or DOACs, prescribed for acute symptomatic pulmonary embolisms and proximal deep vein thrombosis.
Millions of people rely on them every single day.
Yeah, millions. Yet until this specific study came along, there was this lingering, really uncomfortable uncertainty in the medical community, like which one of these two DOACs actually carried a higher bleeding risk when you put them head to head.
And that uncertainty is a big deal for clinicians. I mean, they've been prescribing these medications daily for years.
Because they work?
Yeah. Oh, absolutely. They are highly effective at halting the progression of clots.
Yeah.
And we moved away from older drugs like warfarin precisely because these newer DOACs don't require that constant blood monitoring.
Oh, or those severe dietary restrictions.
Right. But without definitive, randomized, data-driven answers on which of these two specific drugs navigated that dangerous tightrope more safely, well, doctors were often forced to rely on indirect comparisons.
Or just purely observational data, which isn't ideal.
Not when lives are on the line, no.
So today, we're settling this medical heavyweight bout using hard data. But before we get into the actual mechanics of the trial, I think we need to understand exactly what we are treating.
That's a good place to start.
Okay, let's unpack this. We're talking about acute venous thromboembolism, which in this study means patients suffering from either an acute symptomatic pulmonary embolism, so a clot in the lungs, or a proximal deep vein thrombosis, which is a deep clot usually in the leg.
Both of which are immediate, life-threatening emergencies.
Right. And I like to think about it using an analogy. Imagine trying to clear a severe traffic jam on a major highway using a massive snowplow.
I like that. A snowplow.
Yeah. So you have to use enough force to break up the blockage, which is the clot. But if the plow is too aggressive, or if the driver's incareful, it destroys the guardrails and rips up the road itself.
And destroying the road, in this case, is causing a major bleed.
Exactly. So both Apixaban and Rivaroxaban are designed to be that snowplow. They're both in the exact same class of drugs.
Right. They're both factors N inhibitors.
But we need to figure out which one navigates the road more safely. So if we look at the human coagulation cascade, it's essentially this highly complex biochemical domino setup.
A very fragile setup, yeah.
We have the intrinsic pathway and the extrinsic pathway, and they both react to tissue damage. But they both converge at one crucial bottleneck, which is factor X.
Factor Z, to be specific, which is the activated form of factor X, it's basically the grand central station of blood clotting.
Grand central station, I like that.
It's the primary enzyme responsible for cleaving prothrombin into thrombin. And then thrombin converts fibrinogen into fibrin, which is what actually creates the physical structural mesh of the blood clot.
So by inhibiting factor Z, Apixaban and Rivaroxaban are effectively just pulling that bottleneck domino right out of the sequence.
Precisely. They stop the cascade right before the critical structural formation of the clot can happen.
But wait, if they both target the exact same enzyme, the exact same domino, why would there be any difference in their bleeding risk profiles at all? I mean, chemically, they are achieving the exact same blockade.
It's a great question. While they do target the same receptor, their molecular structures, their binding affinities, and most importantly, their pharmacokinetics are distinct.
Okay, pharmacokinetics, how the body processes them.
Exactly. It comes down to how the human body absorbs, distributes, metabolizes, and excretes these specific molecules. So, for instance, Rivaroxaban has a slightly lower systemic bioavailability when it's taken without food.
Oh, compared to Apixaban.
Yes. And it also relies more heavily on renal clearance. So, if a patient's kidney function fluctuate even a little bit, their plasma concentration of Rivaroxaban can actually spike.
Which would push them way closer to the bleeding side of that tightrope.
Exactly. Whereas Apixaban has multiple elimination pathways. It relies more heavily on hepatic metabolism, which can offer a much more stable plasma concentration, even if the patient's renal function dips slightly.
Wow, okay.
Yeah.
That sets the stage perfectly for the trial itself. Because the researchers needed to isolate these subtle pharmacokinetic differences in real human patients who were facing life-threatening clots.
Not an easy thing to do safely.
Not at all. To do that, they engineered this international trial with a 1-to-1 randomization ratio. They basically took a massive pool of eligible patients suffering from acute VTEs and essentially flipped a coin. Half got Apixaban, half got Rivaroxaban.
A classic head-to-head setup.
But the specific architecture of the trial is what really caught my attention. It was built using a prospective, randomized, open-label, blinded endpoint design, which is often called a POA design.
What's fascinating here is how the PRB design deliberately solves one of the biggest ethical dilemmas in acute cardiovascular trials.
Because you can't just give someone with a pulmonary embolism a sugar pill.
Exactly. So, prospective and randomized ensures the study moves forward in time with chance assignment, which eliminates selection bias. But the open-label, blinded endpoint structure is where the real innovation is.
Okay, break that down for us.
So open-label means that the treating physicians and the patients knew exactly which anticoagulant was being taken. There were no placebo sugar pills and no masked drug identities.
Which honestly seems completely counterintuitive if you're trying to prevent placebo effects or bias. I mean, usually the gold standard is a double-blind trial where literally nobody knows what the patient is taking. Why abandon that here?
Because of the high-stakes reality of treating thromboembolisms. Think about it. If a patient in this trial gets into a severe car crash and is rushed to the emergency room with internal bleeding,
Oh, wow.
the trauma surgeons cannot wait around to unblind a trial protocol to figure out what blood thinner the patient is on.
They'd lose the patient.
Exactly. They need to know instantly whether to administer a specific reversal agent, like indexinate alpha, or to use prothrombin complex concentrates. So blinding the treating physician in an acute coagulation trial is simply not safe, and it's not practical.
That makes the open-label necessity incredibly clear. But then you run the risk of the doctor's inherent bias skewing the results, don't you?
Yeah.
Like, if the doctor subjectively thinks Apixaban is better, they might subconsciously downplay a minor bleeding event in a patient taking it.
That is exactly why the endpoint is blinded.
Ah, the medical judges.
Right. The medical adjudicators, these highly specialized judges, tasked with reviewing the patient files at the end of the trial to score the bleeding outcomes, they are kept entirely in the dark.
So they don't know who took what.
Not at all. All identifying markers of the drug are scrubbed from the clinical narratives they review. They just see the lab results, the hemoglobin drops, the clinical interventions, and then they rule whether a clinically relevant bleed occurred.
So the treating doctor knows the drug to keep the patient safe, but the referee scoring the safety outcome is blindfolded to preserve the data integrity.
It's an incredibly elegant solution to a massive ethical hurdle.
It really is. But here's where we need to interrogate the methodology a bit, because looking at the source material, the dosing schedules just jump right off the page. Both sets of patients were treated for 3 months. But the regimens for the two drugs diverge wildly right out of the gate.
They do, yeah.
So for Apixaban, patients were given an intensive loading dose of 10 milligrams twice daily, but only for 7 days. And after that single week, the dose dropped to a maintenance level of 5 milligrams twice daily.
Right, so a brief aggressive induction to halt the acute clot progression, followed by a rapid step down.
Now compare that to Rivaroxaban. Patients there were given 15 milligrams twice daily for a full 21 days before stepping down to a single 20 milligram daily dose.
A significant difference.
Wait a minute. Apixaban drops its heavy dose after just 7 days, but Rivaroxaban forces the patient to stay on a concentrated heavy loading dose for 3 full weeks. doesn't that structurally stack the deck against Rivaroxaban?
It's a very fair point to raise.
Right. I mean, by subjecting the Rivaroxaban cohort to an extra 2 weeks of intensive anticoagulation, the trial inherently exposes them to a prolonged window of vulnerability. It almost seems engineered to generate a higher bleeding risk.
The initial glance at those schedules absolutely invites that skepticism. It looks like an asymmetric variable that corrupts the control of the experiment.
Right.
However, those schedules were not arbitrary inventions of the trial designers. They are the strictly mandated, globally approved, standard of care prescribing guidelines established by the respective pharmaceutical manufacturers and regulatory bodies.
So the researchers couldn't normalize the doses without violating how the drugs are legally supposed to be used out in the field.
Exactly.
But why did the manufacturers design them so differently in the first place? If they both inhibit factor ZAC, why does Rivaroxaban need 21 days to do what Apixaban does in 7?
It traces directly back to the pharmacodynamics we discussed earlier, specifically regarding half-lives and that transition to maintenance therapy.
Okay.
Rivaroxaban's manufacturer designed its maintenance phase to be a once-daily 20-milligram pill, which, is highly attractive for patient compliance.
For sure. People definitely prefer taking 1 pill a day over 2.
But a once-daily dosing of a drug with a relatively short half-life, around 5 to 9 hours, creates significant peak-to-trough fluctuations in the blood plasma.
It spikes and then drops way down.
Right. So to ensure the acute clot is fully stabilized before dropping the patient into that fluctuating once-daily rhythm, the pharmacological protocol requires a prolonged 21-day, twice-daily loading phase. They have to thoroughly saturate the system and suppress the initial thrombotic storm.
Ah, I see. And Apixaban is dosed twice daily for the entire duration of the therapy.
Exactly.
So that twice daily rhythm keeps the blood plasma concentration in a much tighter, more stable therapeutic band, meaning they don't need to aggressively saturate the system for nearly a month. They can step down to the maintenance dose in just 7 days because that twice daily dosing prevents those massive drop-offs.
Precisely. If the researchers had altered these schedules to make them structurally symmetrical, say, by forcing Rivaroxaban into a 7-day loading phase, they would actually be underdosing the Rivaroxaban patients according to its pharmacological profile.
Which could cause fatal pulmonary embolisms.
Yes. The clinical trial must evaluate how the drugs actually perform when prescribed to human beings using the optimized real-world protocols.
So the discrepancy isn't a flaw at all. It is the very variable being tested. We are testing the entire pharmacological strategy of Apixaban against the entire pharmacological strategy of Rivaroxaban.
That's the perfect way to frame it.
Well, with that framework established, let's look at the numbers. They started with 2,760 randomized patients. And over the course of the 3-month trial, they gathered valuable data from 1,345 patients on Apixaban and 1,355 patients on Rivaroxaban.
A really robust, tightly matched sample size.
Definitely. Now, the primary outcome those blinded adjudicators were looking for is defined by the International Society on Thrombosis and Hemostasis as clinically relevant bleeding.
And that's a composite metric.
Right. It includes major bleeding, which encompasses fatal bleeds, bleeding into critical organs like the brain or the spine, or bleeding that causes a massive drop in hemoglobin requiring transfusions. But it also includes clinically relevant non-major bleeding.
And we really shouldn't let the term non-major trick us into thinking these are trivial events.
Well, not at all.
A clinically relevant non-major bleed requires medical intervention, an unscheduled contact with the physician, or an interruption of the study drug. We are talking about severe gastrointestinal bleeds that require endoscopies, heavy epistaxis requiring nasal packing, or prolonged hematuria.
Things that severely impact a patient's quality of life.
Yeah, and they often lead to patients just abandoning their anticoagulant therapy altogether, which then, of course, exposes them to another fatal clot.
The clinical stakes for this metric are just massive. So out of the 1,345 patients in the Apixaban group, a clinically relevant bleeding event occurred in 44 patients. That is an incidence rate of 3.3%.
Okay.
In the Rivaroxaban group, out of 1,355 patients, a clinically relevant bleeding event occurred in 96 patients. That translates to 7.1%.
And the relative risk calculated from those two incidence rates is 0.46, with a p-value of less than 0.001.
Here's where it gets really interesting. Because to a layperson outside of pharmacology, looking at absolute numbers like 3.3% versus 7.1% might not trigger an immediate alarm. I mean, it is a difference of roughly 3.8 percentage points.
Right, sounds small on paper.
But in the context of clinical pharmacology and population health, An absolute difference of that size in a severe adverse event is seismic. Let's dig into that relative risk of 0.46.
Sure, absolute numbers tell you the overall event rate in the specific trial population, but relative risk tells you the comparative power of the intervention. A relative risk of 1.0 would mean the two drugs carry the exact same bleeding hazard.
So a tie.
Exactly. But a relative risk of 0.46 means that by choosing Apixaban over Rivaroxaban, you are cutting the likelihood of a bleeding event by 54%.
A 54% reduction.
Yes. When managing a drug class where hemorrhage is the primary limiting toxicity, finding a compound that reduces bleeding events by over half compared to the prevailing standard of care.
That's a paradigm shift.
It absolutely is.
Mhm.
And the p-value being less than 0.001 indicates that the statistical probability of this 54% reduction being just a random fluke of the patient's sample is essentially zero. The finding is highly significant.
So the data strongly suggests that Apixaban's specific pharmacokinetic profile, whether it's that shorter 7-day loading phase, the twice-daily steady state, or its multi-pathway clearance, all of that translates to a vastly safer physiological experience for the patient.
That's what the data is pointing toward, yes.
But safety is only half the tightrope. Did that 54% reduction in bleeding come at the cost of efficacy? Like, if Apixaban is causing less bleeding, is it also failing to stop the blood clots?
That is the necessary follow-up question, because a drug that doesn't cause bleeding but allows a fatal pulmonary embolism is totally useless.
Right.
To answer that, we look to the trial's secondary outcomes, which tracked mortality and other serious adverse events over that 3-month window. In the Apixaban group, death from any cause occurred in only one patient, or 0.1%. In the Rivaroxaban group, 4 patients died, representing 0.3%.
Wow.
The relative risk there was 0.25.
So not only did Apixaban not sacrifice efficacy to achieve its safety profile, it actually trended toward better overall survival.
No.
Though to be fair, with such low absolute numbers, both drugs are clearly highly effective at their primary job of stopping fatal clots.
Absolutely. They both do their primary job very well.
They also track serious adverse events entirely unrelated to bleeding or thrombosis. So essentially looking for off-target toxicity. And those numbers were practically identical. 36 patients on Apixaban, which is 2.7%, and 30 patients on Rivaroxaban, which is 2.2%.
So the broader toxicity profiles are essentially matched. The crucial divergence occurs almost exclusively in the hemorrhagic complications. And that seems to be driven heavily by that early treatment phase where Rivaroxaban maintains its intensive dosing schedule.
So what does this all mean? We have examined the mechanism of factor SAN inhibitors, we've scrutinized the PRE trial design and the realities of standard of care dosing, and we've analyzed the incidence rates.
It's been quite the journey.
It has. And the conclusion is unambiguous. If you are treating an acute venous thromboembolism over a 3-month period, the risk of clinically relevant bleeding is profoundly lower with Apixaban than with Rivaroxaban.
If we connect this to the bigger picture, this data represents a tangible shift in clinical decision-making. Medicine is rapidly moving towards shared decision-making models. When a physician diagnoses a DVT or a pulmonary embolism, the immediate protocol is anticoagulation.
Obviously, you have to stop the clot.
Right, but the choice of which DOAC to prescribe often comes down to systemic inertia or just insurance formularies.
Yeah, the patient is usually just handed a prescription and told, here, this will stop the clot. They are rarely briefed on the comparative pharmacokinetic risks of the specific molecule they are being given.
Exactly the point. Knowing that Apixaban carries a 54% relative risk reduction for bleeding events compared to Rivaroxaban transforms the patient from a passive recipient of care into an informed advocate.
That's so empowering.
It is. If a physician defaults to a Rivaroxaban prescription, the informed patient can actively ask, hey, given my kidney function and the recent trial data showing a significantly lower bleeding risk with Apixaban's dosing profile, is there a specific contraindication preventing us from using Apixaban?
It leverages high-level trial data as a protective tool right there in the clinic. You are navigating the tightrope, but you now have the data to choose the balancing pole that mathematically offers the highest degree of safety.
The clinical utility of this specific study just cannot be overstated for that 90-day acute treatment phase. It offers an incredibly clear resolution to the heavyweight debate for short-term anticoagulation.
Which naturally leads us to the unknown territory beyond the parameters of the study, because this trial offers a high-fidelity snapshot of a strictly bounded 3-month window.
Right, 90 days exactly.
We know exactly how these two pharmacological strategies perform over 90 days. But acute VTEs are often just the first manifestation of a chronic underlying issue. patients with severe genetic thrombophilias, like factor V Leiden, or patients who suffer recurrent, unprovoked pulmonary embolisms, they do not stop taking DOACs after 3 months.
No, for a significant percentage of the cardiovascular population, anticoagulation is not an acute intervention. It is a permanent, lifelong necessity.
And that is the lingering question. If the bleeding risks between Apixaban and Rivaroxaban diverge this drastically, I mean, a 54% reduction in relative risk after just 90 days of exposure, what does that divergence look like over a decade?
It's a sobering thought.
Do the daily peak-to-trough plasma fluctuations of Rivaroxaban's once-daily dosing compound the microtrauma on the vascular system over 5 or 10 years? If you are forced to walk that medical tightrope for the rest of your life, how profoundly does the choice of that specific factor ZAS inhibitor shape your long-term survival?
We really need more data on that.
We do.
Yep.
It is a question the data hints at, but one the medical community is still racing to definitively answer. Keep exploring those questions, and we will catch you on the next deep dive.